Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects, as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good evening, everyone. Welcome to the 5th lecture of Neurology series of National Academy of Medical Sciences, Navigate Medico CME program. So first of all, I would like to invite Professor Umesh Kapil sir for the welcome address. He is currently Secretary of National Academy of Medical Sciences. So sir, please, over to you.
Yeah. Good evening to all. Good evening to all participants, respected speaker and Ma'am Padma. We are most grateful to you for helping us and facilitating the NAMS Navigate program. Navigate is essentially national virtual program for postgraduates in different parts of the country. All the postgraduates who are pursuing their MD program, it is essentially meant for them. Also, what we have is those graduates who are interested in doing their post-graduation and wants to pass out the NEET PG examination. It would be helpful for them. The aim of this Navigate program is essentially to update the knowledge and skills of the postgraduates in different parts of the country through online sessions which are being undertaken by the most eminent faculty in the country. We have today Dr. Vishnu, who is Associate Professor in Department of Neurology at AIIMS, New Delhi, and he would be talking about effective management of common neurological disorders. And I know that Dr. Vishnu will do a great justice to his presentation and which would be enjoyed by all the participants. Apart from this, we must remember that out of 100,000 MBBS students who are coming out, only 16,000, 8,000 get into the regular MD-MS program, and about 8,000 they get into DNB program. The rest, about 80 to 85,000 graduates, they aspire to crack the PG NEET examination. And what we do is we invite them free to join this program. This is something very important, a great initiative, keeping in view of the needs of the graduates and postgraduates for doing their MD and MS program. Now, apart from this, what we have done, whatever the lectures and presentations have been done in the Navigate program, we upload them in the NAM's website, and these NAM's website lectures, video presentation, PowerPoint is available to all the students in a virtual manner for all time to come. So it's a virtual library for the postgraduates. We also ensure that these lectures and presentations are transmitted, teletransmitted on the YouTube. And I understand from my IT colleague, there are about 287 people who have joined online on the YouTube and likely to be get benefited. With these few words, I again welcome the Ma'am Padma, Dr. Vishnu, and I request them to please help us, and we look forward to your continued help and blessings for the National Academy of Medical Sciences. With these few words, thank you very much.
Thank you, sir. Thank you for your kind words. So now I would like to welcome, and first I would like to introduce Dr. Vishnu V. He is currently Associate Professor in the Department of Neurology at AIIMS, New Delhi. He is ICG NMD MRC Faculty Fellow, Neuromuscular Genomic Medicine. He is a World Stroke Organization Future Leader. His areas of interest are neuromuscular disorders, stroke, CNS vasculitis, artificial intelligence, and evidence-based medicine. He has been awarded with numerous awards like American Academy of Neurology, International Scholarship Award 2015, World Stroke Congress, Young Investigator Award 2018, Department of Science and Technology, SCRB Early Career Award 2017, World Muscle Congress Elsevier Award 2022, David Sackett Memorial Award, Health Research Method and Evidence-Based Medicine, St. John's Hospital in collaboration with McMaster's University, Canada. He has more than 160 publications, and he has been a principal investigator, co-principal investigator of around 10 extramural projects. So with this, I would like to again welcome Vishnu sir. Sir, welcome, sir. And I would like to hand over the hand over the session to the sir. Sir, please.
Thank you very much for the kind introduction. So I will just share my screen. Can you see my screen?
Yes, sir, visible.
Okay. So I will be talking about today. Good morning, everyone. Good evening, everyone. So I'm Vishnu. I'm Associate Professor of Neurology at AIIMS Delhi. So I'll be talking to you about approach to nerve and muscle disorders. So, okay. So I have nothing to disclose. So what we will try to do, it's a huge topic to combine both approach to nerve and muscle together, and there's a neuromuscular junction in between also. But we'll try to create in a nutshell what we can cover in 1 hour session. So usually we do it as approach to neuropathy separate and approach to muscle disease separately. So we have so what we plan is to find out how to localize them, look at the history and examine, look at the pattern recognition and an overview of investigations that we do. So before going into that and properly, so in any localization, you want to know whether it is an upper motor neuron or a lower motor neuron. So nerve and muscle disorders are lower motor neuron lesions. So, but you also want to know whether it's a pure LMN lesion or there is an associated UMN lesion with them. So if it's pure LMN lesion, it's an anterior horn cell or dorsal root ganglia, root plexus, nerve, neuromuscular junction, and muscle. So we'll be concentrating more on the nerve and muscle part. So before going into details, so we want to know what's the difference between lower motor neuron versus the peripheral nervous system. So lower motor neuron includes the anterior horn cell, which is situated inside the spinal cord. I don't know whether you can see my cursor or not, but inside the anterior horn cell is also involved, where the anterior horn cell here is also involved, whereas the peripheral nervous system is anything outside the dura mater. So all the radical cells starts the peripheral nervous system. So it can, sometimes these all could be a multi-system disease, not just involved in the neurology. It may be multiple neuroaxes may be involved, or in outside the neuroaxis, other systems may also be involved. So everybody should be knowing that the human is a motor neuron cell body which lies within the motor cortex in the brainstem, the motor cortex of the cerebrum or the brainstem. So the axons form the corticobulbar and the corticospinal tracts. So they terminate in the cranial nerve nuclei or in the anterior horn cell, from where on and the lower motor neuron starts with. So it's the anterior horn cells of the spinal cord or the motor nuclei of the brainstem is what constitutes the lower motor neuron. And these cells comprise the anterior spinal root, spinal nerves, cranial nerves, and innervate the muscles. So one concept that you should understand is that even if it's that single motor axon, which is supplying the tip of the great toe, the axon comes, a single axon is the one which is coming all the way from the spinal cord to that region. So it's not like they're not going getting multiple connections within the leg and going there. So you have a single axon going all the way down there. That's concept is important when you look at length-dependent neuropathies and metabolic and toxic neuropathies. So practically, lower motor neuron is used to denote the anterior horn cell, radicals, plexus, peripheral nerves, neuromuscular junction, and the muscle. I mean, the difference between upper motor and lower motor, I think you all know. We'll skip this. So we are the neuromuscular disorders. Here we'll our topic for today is to approach both neuropathy and muscle. There's neuromuscular junction also in between. So we'll just summarize how they differentiate between them. So neuropathy is an element lesion. So usually predominantly it's a distal weakness, but you can still get a proximal, rare presentations of a proximal neuropathy also. Well, you'll have most of the time you'll have a sensory involvement in neuropathy unless it's a pure motor neuropathy, which is still possible. There will be hyporeflexia or areflexia, but if there is a coexistent human lesion, you may still get a hyperreflexia like in the motor neuron disease or somewhere. If even it's or some other disease like HSP or a complicated HSP where you get both human and a neuropathy or a mitochondrial disorders like that. It could be usually length dependent, but it could be non-length dependent also. Length dependent means the more distal parts of the body are first affected and slowly ascends upwards. By the time it reaches the knee, the hands and the tip of the fingers are affected. So that's the length dependent. Sometimes non-length dependent neuropathies like demyelinating neuropathies like CADP, organ be non-length dependent when both proximal and distal parts are simultaneously affected. Then you can sometimes you get an autonomic involvement, isolated or pure autonomic neuropathies also. As I said earlier, proximal weakness can also occur in sometimes some kinds of neuropathies. So now coming to the neuromuscular junction, which is between the muscles. So it is a low motor neuron. It mimics like a muscle disease. It also has a proximal weakness, but it'll have fluctuations and fatigability. That means sometimes vision looks normal, then after exercise or something, the weakness worsens. And predominantly characteristically, they have extraocular movement. That's called the characters. The prototype of a neuromuscular junction is a myasthenia gravis, where you get a ptosis and an ophthalmoplegia involvement. Autonomic involvement, it can occur in another neuromuscular disease called Lambert-Eaton myasthenic syndrome, or the LEMS that we call it. It can have an auto. So anyone with a proximal involvement and autonomic involvement, you think of Lambert-Eaton syndrome. Now coming to the muscle disease, it could be acquired or hereditary. It's also an element lesion. It predominantly has proximal weakness, but some the classical distal myopathies are also there. We get a distal weakness also. And usually the plexus are preserved, and there is no sensory involvement in muscle disease unless it's a pure muscle disease or something. It's complicated and you get something else together along with that. So if you classify these disorders into multiple things, for example, neuropathy, it could be focal or generalized. Focal can be a radiculopathy or a plexopathy or a mononeuropathies. It could be one part or a particular group of nerves could be affected, or a generalized. It could be symmetric or asymmetric. Generalized is a classical polyneuropathy, symmetric polyneuropathy that you see commonly, and then it could be an asymmetric like multiple mononeuropathies, which we used to earlier call as mononeuritis multiplex. And if neuromuscular junction is usually classically is myasthenia and LEMS, but it could be hereditary like a congenital myasthenic syndrome. Where there are a lot of myasthenics, a lot of antibodies, which can be positive like a step-only receptor antibody, MuSK, and LRP and other antibodies can also be positive, and Lambert-Eaton myasthenic syndrome is also there. So I think we will limit our discussion neuromuscular junction here because there's no time to discuss more on this. So we'll be focusing more of the nerve and muscle. I will mention a few things when the differentials comes at that point of time. In acquired, it is mainly hereditary and acquired myopathies. Acquired is more commonly in inflammatory myopathies, endocrine myopathies, drug-induced, or a toxic myopathy, or some as the myopathy systemic diseases are the acquired ones. In the hereditary, a lot of muscular dystrophies, myotonias, mitochondrial myopathies, metabolic myopathies, congenital and channelopathies are all part of the hereditary myopathies. Now, coming to the history, most of the times the most common symptoms are negative motor symptoms and positive. If you come to symptoms, you get motor symptoms and sensory symptoms. We'll come to first the motor symptoms. So the negative motor symptoms are weakness, fatigue, wasting or atrophy, exercise intolerance, and walking difficulties. These are the most common symptoms. Positive motor symptoms are myalgias, muscle cramps, contracture, fasciculations, myokymia, tremor, myotonia, myoglobinuria. All these things can affect the positive motor symptoms. So if you look at the disorders with diffuse myalgias, like the positive motor symptoms, it's very myalgia is a very non-specific symptoms, and like we don't have any weakness, just myalgias. It could be a lot of other conditions also, but these are the conditions which muscle disorders which can cause disorder. For example, endocrine myalgias, inflammatory myopathies, mitochondrial, metabolic, toxic, and sometimes some Becker's variant also can present with myalgia and cramps. Some disorders can present with contractures like classically McArdle's, some congenital hereditary myopathies like metabolic myopathies like McArdle's, or some other disorders like Bethlehem, Emery-Dreifuss, and laminopathies are also in present with contractures. Important thing to notice that contractures, most of the muscular dystrophies in the very late stage, if they are, especially if you don't do a good physiotherapy and all, if that later on, most of them will develop contractures. But here we are talking about very early contractures in the initial stages of the start of the disease. Then muscle stiffness, we can call as myotonias or a paramyotonia. You can call us all the myotonic disorders, whether it is channel dystrophic or myotonic dystrophy or non-dystrophic myotonia. So it also can cause like myotonic dystrophy type 1, 2, myotonic congenita, paramyotonic congenita. Some periodic paralysis are also can cause myotonias. So myoglobinuria is classically seen acquired conditions. You have got a heat stroke or a neurotic malignant syndrome or prolonged severe exercises, very severe exercise like running a marathon or unaccustomed without any proper training. So those all these trauma, crush injuries, all these things can cause an acquired causes. Familial causes you can get in some amount of metabolic, mostly in metabolic myopathies. And sometimes rarely you can see muscular dystrophies also. So now coming to the most common symptoms like weakness, the most common symptoms, and the classical presentation of a muscle disease is normally it is a proximal weakness, that is lower limb. If it's a lower limb weakness, they come and present as a difficulty in getting up from sitting position, or climbing the stairs, or climbing downstairs, or getting up from a squatting position, or getting up the floor. These are the common symptoms that tell about a lower limb proximal weakness. If it is an upper limb proximal, they will complain about lifting objects overhead, reaching to get things from the top shelves, or brushing teeth, dressing, shaving, or brushing their hair. So all these things are the upper limb proximal weakness symptoms. So if there is a distal weakness in upper limb, they'll complain of difficulty in opening jars, buttoning clothes, or turning a key in the ignition. Lower limb, it will be tripping or difficulty walking on uneven ground, or foot slapping, especially if you have a foot drop, difficulty in wearing chappals. Cranial muscle weakness, if they have a associated cranial muscle weakness like ptosis or thanoplegia, and facial weakness, all these things symptoms can be, or dysphagia can be presented in that way. Sometimes there may be precipitating factors like exercise, fever, carbohydrate meal, pain, especially in periodic paralysis, cold exposure, especially in myotonia and paramyotonia. So all these things can precipitate an exercise in, especially in myasthenia, or symptoms can precipitate, or in metabolic myopathies can precipitate a weakness or myoglobinuria at that point of time. For example, this table also gives us a distribution of weakness, how each of the, for example, facial weaknesses, they're unable to bury the eyelashes, they may have a horizontal smile, they can't whistle. Sometimes these mild weaknesses are unnoticed. They may not notice until you get a frank more weakness elsewhere in the body. Mild facial weakness are usually unnoticed, and sometimes they say that they sleep from childhood itself with the eyes open, or the mouth. His smile is like that. It's a character that runs in his family. They may not identify it as an abnormal unless something else happens. Some other definitive weakness develops in their body. Ocular double vision or ptosis, because conjugate eye movements, bulbar associated nasal speech, or dysphagia dysarthria happens. Neck weakness, it's poor head control, especially if neck weakness is more common in inflammatory myopathy, or AIDP, CIDP in neuropathy conditions, or in a myasthenia gravis, or in ALS and anterior This is all can have a neck weakness. Trunk weakness may present with scoliosis or lordosis, an exaggerated lordosis, protuberant abdomen. Those trunk weakness may present like that. Shoulder girdle, anyway, forearm weakness we discussed just now, the proximal and lower limb weakness. Now, coming to the sensory symptoms, sensory symptoms are very sometimes tricky. Because they use very vague terms, sometimes vague terms in the sense they may not be able to convey exactly what they are feeling, but they may use multiple words like prickling, searing, burning, tight band-like sensations. But the most characteristics which is easy to understand is the burning sensation. It usually occurs in the small fiber neuropathies, and the tight band-like sensation even involving a posterior column involvement, you might get it. Paresthesia, allodynia, hyperalgesia, pain, all these are positive sensory symptoms. Negative sensory symptoms mainly numbness, so that means loss of sensation. You should be careful when the patient says numbness, because sometimes the people use numbness for a lot of things. Therefore, even for a motor weakness, also sometimes patient use the word numbness. They feel the leg feels numb, but sometimes it may be the weakness is what they're labeling it as numb. So you should be very careful in interpreting what they're sensing as. And if there's a severe large wave neuropathy or a posterior column, make it a sensory ataxia. All these symptoms are there for the negative sensory symptoms. So important thing to know that especially in the case of neuropathies, if there's spontaneously reported paresthesias are helpful in differentiating between acquired from inherited. If you look at in an acquired neuropathy, most of the time patients will themselves send about sensory symptoms. In a hereditary neuropathy, even though on examination they have sensory involvement, they may not complain as such for sensory involvement. They may not test, they may not recognize because very slowly and they adapt better to the mild sensory loss. So weakness may not be appreciated at least 80 to 50 to 80% of nerve fibers are lost. So this is character because the rest of the adaptation of our nerve system is pretty good in that sense. So during hysteresis taking, sensory symptoms often overshadow the motor symptoms because they are very sensitivity, because our pain and sensations are evolutionary is advantage to our human beings compared to so that we should be aware of our threats. So there is our sensory system is very sensitive. Early involvement of the sensory system, redundancy built into our motor system, and mild intrinsic foot weakness that goes unnoticed by the patient. So all these things, only sensory symptoms are the ones which may be first involved. Now, if you look at the symptoms of autonomic dysfunction, you may get an orthostatic intolerance like lightheadedness, pre-symptomal symptoms, so syncope, reduced excessive sweating, heat intolerance, bladder, bowel, or sexual dysfunctions, anorexia, early satiety, nausea, vomiting, suggestive gastroparesis, all these autonomic dysfunctions. You should probe for this question for any autonomic dysfunction or not. Now, coming back to the temporal evolution, so that's very important whether it is an acquired neuropathy or a myopathy, muscle disorders, because age of onset, at whether it's presentation at childhood or at birth or a childhood or around this table shows the different myopathies presenting at different age group. So episodic weakness, for example, if child only having that, it's not a constant weakness, or it's a progressive or a non-progressive. For example, congenital myopathies may not be that much progressive. Rest of muscular dystrophies are progressive. In an episodic weakness, so relapsing remitting weakness, for example, inflammatory myopathy, sometimes they improve with steroids, then again coming back, or an episodic weakness, like they come and go, like periodic paralysis or channelopathies, they can present with an episodic weakness. Okay, then and then acute or subacute progression in sub-inflammatory myopathies like dermatomyositis, polymyositis, or AIDP, CADP can have an acute or subacute presentation. And chronic slowly progression over years could be muscular dystrophies, hereditary neuropathies, or slow progression, and non-progressive weakness will change over decades, so those usually in congenital myopathies. Now, after that, you look at the associated medical conditions, because diabetes is a common cause of neuropathies, hypothyroidism, chronic renal failure, liver disease, intestinal malady, all these things can cause neuropathies, malignancies, can associate both neuropathies and muscle diseases like malignancies, paraneoplastic myositis, all these things are known. Connective tissue disorders can cause both neuropathy or muscle diseases, HIV, also common cause of small fiber neuropathy. Now, drug is an important point, not only in both nerve and muscle disorders, but a lot of things are caused by the drug. Alcohol and dietary habits can cause significant neuropathies. Exposure to solvent, pesticides, or heavy metals, occupation, sexual history, recreational drug use, smoking, childhood history of clumsiness. So we always say that when the patients say that from the age of onset is around 18 years or 20 years, you go by and ask how the child was, how was he when he was a child, where he was well along with his peers, where he was same like his peers, or he was a little slow compared to in running or in poor athletic performance or getting up to in a bus. All these things you should ask whether they are actually exactly normal at that age during childhood or not. Sometimes hereditary causes, the parents may be able to recognize that no, he was not as fit as some of his peers. Now, patients with cancer also may develop neuropathy like nutritional deficiency or drug-induced neuropathy or paraneoplastic syndrome. They even can develop muscle diseases also. Posting effect is something known as aflatoxin neuropathy describes symptom progression for months to a year, despite the agent continuation. It's seen both chemotherapies and HIV-related treatment. Surgical history is important with bariatric surgery, multiple orthopedic procedures, multiple surgery for entrapped nerves. So sometimes maybe think of hereditary neuropathies like HNPP and all something. They may get surgery for multiple entrapped neuropathies. Now, as discussed previously, a lot of drugs which can cause a drug-induced neuropathies. Most common is the chemotherapeutic agents and pyridoxine, phenytoin. Metronidazole disorder is a pretty common drug that we use for liver abscess for a long period of time. Most of them develop some amount of drug-induced neuropathies. Long ATT, anti-tuberculosis therapy can also cause a significant amount of drug-induced neuropathies. Now, as kind of summarizing the history, you should always finally ask about what is the activity in the daily living change environment, like change in handwriting, problems in your day-to-day life. All these things needs to be asked. Then you also look at the review of the other systems involved with the skin changes, arthralgia, dry eyes and mucous membrane, orthostasis, symptoms, constitutional symptoms. Because when you look at the muscle disorders or the nerve disorders, a lot of things can have other systems involved. So a lot of myopathies, muscular dystrophies can have early respiratory insufficiency. Many of them can have cardiac disease along with that. So hepatomegaly is seen in metabolic myopathies, cataract and frontal balding is seen in myotonic dystrophy, optic atrophy, pigmentary retinopathy, multiple lipoma seen in mitochondrial myopathies, rash, the V sign, the Shaw sign, all is seen in dermatomyositis. CNS involvement can occur in mitochondrial and myotonic dystrophy or congenital muscular dystrophies. Some diseases can have both muscle and nerve involvement, like both acquired and chronic conditions, like acquired alcohol, amyloidosis, chronic renal failure, chronic vascular disorders. There are a lot of other conditions like mitochondrial. This can also both muscle and nerve simultaneously get involved. Family history is very important because the ethnic background, consanguinity, all these things will be finally into this one. And rather than having a single blanket question of anyone in the family has been affected, you should ask more details about anyone having a presence of high arched feet, flat feet, hammer toes, skinny legs, any gait dysfunction in the family, anything to suggest an inherited muscle or nerve disorders should be asked about. Examine family members. If you can see a family member, looks for anything, whether the neuropathy aspect or the muscle aspects, whether it's before it. I look for a family member with the history of multi-system involvement, family members with canes, wheelchairs, sculpted deformities, or functional deformity involvement. So these are in the table here. Autism shows the autosomal dominant recessive and the maternal and X-linked different types of muscular distribution can present like that. So challenge, it could be challenging in adopted individuals and from small families. So sporadic cases are common. But phenotypic variability, that's very important. Conditions like myotonic dystrophy and FSHD, you may not obviously get a family history, but if you start examining patients in the family members, you will see that many of them have mild subtle scapular winging or a facial weakness. There are patients who have a foot drop and they still don't recognize that as significant weakness. They have adjusted to it such a long period of time. They don't say that they have no problem unless and until you start examining them. So phenotypic variability are also present, and so you may not the family history may not be completely reliable unless you examine them and the family members. So this is the pedigree nomenclature which everyone should be aware of, so that you can adequately represent a good family tree, which is very important. So, for example, if you in the era of genetic testing of whole exome sequencing and other sequencing tests and other whole genome sequencing coming up, so a good family history tree is very important and to interpret the results that we have. That is not some dominant or some recessive, X-linked recessive, or the mitochondrial family tree that we have, which a good family tree representation, which is very important. So coming to, before going to that, looking a few words about the hereditary neuropathy part, because disease modifying therapies are now started to come up, for example, amyloid neuropathy and all. So, and even HNPP and citizen should be warned of knowing that it will help that trauma mobility and pressure on the peripheral nerves can prevent pressure palsy for those patients. When you suspect a hereditary neuropathy in a generalized polyneuropathy patients, when there is a family history or a lack of positive sensory symptoms, but sensory signs are present on examination, the disproportionate examination findings compared to the sensory symptoms, or a prominent wasting happening, or early age of onset, symmetry, associated skeletal abnormalities, and very slowly progressive course. It's important to identify heredity even if there is no treatment, because a lot of unnecessary immunosuppression can be at least avoided. There are a lot of clues like frequent childhood ankle sprains, toe catching falls, recurrent foot and ankle fractures, regularly being the slowest child in foot races, recurrent acral, paronychia, calluses, and ulcers in sensory predominant forms, instead onset and slowly progressive course, and early pediatric surgery has been done multiple in the legs. They're all clues towards a probably a hereditary neuropathy. And just because there's an absence of family history may not rule out a hereditary neuropathy. Sometimes incomplete penetrance and decreased expressivity of the gene may be involved. An acquired neuropathy happen on top of an inherited neuropathy also. Sometimes there is some rapid accelerated neurological decline may be due to an acquired etiology, more susceptible, and these patients may be more susceptible to metabolic toxic or other insults like chemotherapy. So it could be a double crush phenomenon happening there also. Now, coming to the presenting complaints, if you summarize most of these are the one which you should do when you take a history of the onset, duration, progression, the tempo of the progression, symmetric or asymmetric, systems involved, location and systemic features, drug family history, and activity of daily living, and try and fit into it. Is whether there's a typical feature or atypical. There's an odd points which are these for that. Once you localize it to nerve or muscle or nerve connection, then try and find out which is typical or atypical or a pure or a complicated case where multi-system is involved or not. So coming to now we'll discuss predominantly on the neuropathy first, then we'll go to the muscle disease part. So in acute polyneuropathy, that's which everyone we are likely to face in emergency and in outpatient clinics. Guillain-Barré syndrome is the most common. Then acute peripheral neuropathy, toxic neuropathies, critical illness neuropathies, vasculitis, infection neuropathies are the one common. Chronic polyneuropathies, diabetes and metabolic drug-induced toxic metals, immune-mediated like CADP and its variants, hereditary neuropathies. Most of the hereditary neuropathies will come in the chronic or the beta deficiencies, paraproteinemia, connective disorders, some infections, and mitochondrial are coming in the chronic polyneuropathies. So important to know that patients with chronic polyneuropathy can also develop subacute worsening due to other processes. For example, a diabetic patient with a chronic axonal sensory motor polyneuropathy can have a subacute worsening if you have a superimposed radiculoplexiopathy or radiculopathy. If you have a common fibular neuropathy across the fibular head or a lumbosacral plexopathy, or even they can have a CADP. So all these things can superimpose can have worsening during that time. Patients in CMT or a Charcot-Marie-Tooth disease or a hereditary neuropathy can also develop superimposed and rapid neuropathies or a second etiology like CADP. So, or as sometimes a classical double crush like cervical radiculopathy and a carpal tunnel syndrome can occur on the same patient. So, if you just for the localization purpose, we look at this, all these from the motor neuron to muscle, all these things can present acutely. Like in a motor neuron, acute flaccid paralysis or a paraneoplastic syndrome can present acutely. Spinal disc herniation or a varicella zoster varus neuron radiculopathy can acutely. Sensory neuron paraneoplastic Sjogren and toxicity can pyridoxine toxicity can present acutely. Plexus, okay, neurologic amyotrophy, diabetic lumbosacral radiculopathy can present acutely. Nerve, the drug toxin mononeurtis multiplex, AIDB, all can present acutely. Neuromuscular junction, if it is botulism, can present acutely. Muscle disease, inflammatory myopathies, and toxic myopathies can present acutely. If you look at the recurrent relapsing remitting on an episodic, CADP or in a neuro part or inflammatory myopathies in the muscle part can present within a recurrent relapsing remitting part. HNPP, periodic paralysis, metabolic myopathies can present episodically, porphyria, repeated toxic exposure, vasculitis, all can present like recurrent or relapsing remitting format. The characterization of a neuropathy is important. You look at the temporal profile, onset and duration, try and identify which is the hereditary versus acquired. Try and transfer into anatomical class with the large fiber, small fiber involvement is there. Then identify and the etiology. So, for example, in the fiber type anatomical classification, the motor versus sensory, large versus small, somatic versus autonomic, the portion of the fiber, there's an axonopathy or a demyelination involved, cross distribution, there's a length and non-length dependent or a multifocal involvement is there or not. So look at the general physical examination points. If you look at orthostatic vital signs, may identify evidence of autonomia, skin and mucous membrane. Look at the vascular rashes for a purpura, oligoreticularis, cryoglobulinemia for purpura, angiokeratoma. You can see Fabry's disease, Hyperpigmentation may be seen in Poem syndrome. Hypopigmentation you can see in leprosy. Oral ulcers you've seen Behçet and HIV. Bullous lesions in porphyria. Salivary gland involvement, dry mouth. You can see sarcoidosis and Sjogren. Hair loss you can you've seen lead exposure. Then measles, lines, and you can see in arsenic or thallium poisoning. Alopecia, you can see in a lot of conditions like hypothyroidism, cilia, amyloidosis, or thallium poisoning. Curly hair, you can see in gender axonal neuropathy. Distal half hair loss, it's in the classical distal symmetrical sensory neuropathies. Skeletal deformities are important, especially in inherited polyneuropathies like hamartosis, pes cavus, and cavus scoliosis. Peripheral nerve palpation is important. Nerve thickening, look for the nerve thickening. The common sites that you look for are the ulnar nerve at the elbow, radial sensory nerve at the radial wrist, greater auricular nerve behind the ears. nerve enlargement, usually you can see it in a demyelinating neuropathy or a neoplasia in neurofibromatosis or classical leprosy. In joints, you look at the rheumatological conditions in the Charcot joint, and the hypermobile joint may be seen in Ehlers-Danlos syndrome. Look for scapular winging, that's important, not only in just neuropathy, also in muscle. A lot of muscle disorders can present like FSHD, can come present with isolated scapular winging. Muscle atrophy and contractures usually denotes chronicity. Contracture of the elbow is usually seen in a myopathic process that we discussed earlier. It could be early contractures in the elevator phase or batellar myopathy or laminopathies can all have a very early contractures. Contractures, the angle can occur in a lot of other processes also, chronic disorders. This is just a out of how each it can be a neuropathy. Hereditary neuropathies can be a multi-system disorders, not just involved in the neuropathy, but other part of the these are the genes involved in different part. We do not know everything about this, but at least important to know that in a hereditary neuropathy is just not related to nerve, but it can involve other part of eyes, brain dementia, learning difficulties, optic atrophy, hearing impairment, vocal cord paralysis, cerebral syndrome. All these things can be affected. So these are the some of the other features which can present in a hereditary neuropathy. To be focused, you get a cranial examination. You get something called an anosmia. You see in the Russell disease or a B12 deficiency. In optic atrophy, you can see in both inherited neuropathy, central and peripheral demyelination, or in the mitochondrial disorders. Anisocoria, you can see in the parasympathetic dysautonomia, impaired ocular motility. In nerve disorders, you see in botulism and Miller-Fisher syndrome. In myasthenia, obviously, they'll be there. Even in central nuclear myopathies, like congenital myopathies, also can you get oculomotor involvement. Facial weaknesses can be seen both AIDP, CIDP in neuropathies and also in a lot of muscular disorders and even in myasthenia, you can get a facial weakness. Trigeminal sensory loss is characteristically seen in Sjogren's, and hearing loss you can see in mitochondrial myopathies or mitochondrial neuropathies. Bulbar involvement you can see in both Guillain-Barré syndrome or later stages of even inflammatory myopathies you can see. Now, facial nerve involvement is very common in neuropathy. With facial nerve involvement, this is likely to encounter in GBA, sarcoid, leprosy, infections like leprosy, HIV, Lyme, and syphilis, leukemia, lymphoma, leptomeningeal carcinomatosis, in vascular conditions like the GPA, Sjogren, or in rare conditions like Jaitanges, insulin. Even CIDP can have, it's not as common as AIDP, but CIDP can also have some amount of facial weakness. If you have a recurrent ipsilateral facial neuropathy, look for suspicion of neoplastic pathology like facial schwannoma, parietal tumor, or acute neuroma. Immune mediators or sarcoidosis, Merkel syndrome. If you have bilateral facial neuropathy, you've got GBS, neurosarcoidosis, HIV, leptomeningeal carcinomatosis, lymphoma, leukemia, Lyme, and syphilis can also be involved. Now, coming to the trigeminal nerve involvement, neuropathy with trigeminal nerve involvement, it could be a Sjogren, it should be on your top of your list. Diabetes, obviously, diabetes can cause leprosy, HIV, Lyme, and the rest of the usual causes. Some of the first one can also cause it, maybe involves the presence of nuclei also, but many of some drug-induced and dangers and fabrics also can cause some of the trigeminal nerve involvement. So you have to involve which system involvement is a motor predominant involvement neuropathies like porphyria, lead poisoning, MMN, multifocal neuropathy, and GPS are also mainly a proto predominant, even sensory can occur. CIDP predominantly motor involvement. Mimic a lot of mimics like motor predominant neuropathies like ALS, SMA, Kennedy's, distal myopathies can mimic like a motor predominant neuropathies. Major differentials are when you have a motor predominance localization wise to motor neuron disease or MMN or distal myopathies. Always look for human plus elements features. Focal involvement and investigation in multifocal motor neuropathies may have some mild sensory symptoms, but not clear sensory signs. Autonomic neuropathies, okay, diabetes is the most common cause, followed by GBS, then toxic, paraneoplastic. Some amount of neuropathies can cause autonomic neuropathies and some infections and neuropathies related to amyloidosis. Sensory predominant, again, diabetes is the most common. Sometimes you can get other toxin, amyloid, vasculitis, HIV, paraneoplastic, and sensory CIDP, chemotherapy induced and B6 toxicity, Friedrichs, and some infections can cause a sensory predominant neuropathies. Sensory ganglionopathies is modern because it's the sensory counterpart of a motor neuron disease where the dorsal root ganglia are involved. So the patients are severely sensory ataxic. Sometimes they may not be able to sit or stand, so that makes severe attacks. It's usually seen as a paraneoplastic. Sometimes we see immediately along with Sjogren's, chemotherapy-induced vitamin B6 toxicity. Sometimes part of this canvas syndrome, like sensory cerebral attacks and neuronopathy and vestibular reflexes syndrome, so later on cerebral attacks, which It's usually present like with the cellular ataxia and vestibular reflexia and neuronopathy. Now coming to the motor system examination, most neuropathies have distal weakness. So intrinsic foot muscles are the first affected. You get a clawed feet and hammer toes, weakness and flexion extension of the small toes, and weakness of the great toe extension. The angle between the shin and unsupported foot usually be approximately 130 degrees. So larger angles suggest a frangal dorsiflexion weakness. Observe the gait, standing up from the chair without the use of hands to push up, walks on the toes and heels. In length dependent neuropathy, patients have more difficulty in heel walking than the toe walking. Now coming to the examination clues, so we had a typical features of a chronic neuropathy, such as like a champagne leg, champagne bottle appearance, or the foot pescavers and the hammer toes. All these things suggest you have a chronic neuropathies. Foot drop is usually what are the clues towards hereditary neuropathy? Foot drop identified by a doctor but not appreciated by the patient. High arches and hammer toes, inverted champagne bottle appearance, sensory loss without sensory symptoms, palpable large nerves, exuberant plantar callus from valgus or paraspiform. These are all suggest a very chronic process in the patient, which is hereditary neuropathy. Now coming to the sensory system, we usually anatomically describe a small favor, loss of pain or light touch, the loss of proprioception, JPS and vibrations is affected. Light touch evaluation, low threshold mechanoception at monofilament at 10 gram you use. Difficulty between a sharp and a dull stimuli, if nociceptive fibers related to low threshold mechanofiber sensory ganglionopathy, as I told earlier, there is a severe proprioceptive loss. If there is pseudoathetosis or a piano of playing fingers, when you ask the patient to close the eyes and keep the fingers stretched, they suddenly have a piano playing fingers, called a pseudoathetosis because of the severe sensory ataxia. Testing pinprick sensation should always start in the area with suspected sensory deficit, then move to the area of a normal sensation. One should avoid touching the pin on the patient's skin repeatedly to avoid the phenomenon of temporal submersion. So you should touch one at a time. And pressure of the pin against the skin should be held constant as much. So yeah, the idea is to reproducible and objective monitoring. Vibration usually use the 128 hertz for the vibration. Time interval under perception is lost is measured. One young adult at the vibration rate should last for around 15 seconds. This value might decline 1 second per decade, but vibration perception of less than 10 seconds at rate at any age should be taken as abnormal. Sites you look at toes, dorsal foot, angle, mid-shin, knee, and hip. The distal phalanx of the finger, knuckle, wrist, elbow, and shoulder are the sites that we test for vibration. Joint position is less sensitive than vibration for large fiber function, but maybe bad and severe. So these are the two things that you look for: vibration and JPS for the large fiber involvement, other than the reflexes, which is also be affected in a large fiber neuropathy. Joint position is tested in the grade 2 and the second finger of the distal interphalangeal joint. This should be held by the lateral borders. Should be done laterally, not on the upside down, so that they don't get a feel of which side just because of how you hold the finger. Proximal joints are tested. If the distal impairment is present, you will make the minimal movement and slowly increase the degrees. Speed and degree of the passive movement should also be consistent. So how you differentiate that's one large fiber neuropathy versus ganglionopathy versus posterior column involvement? In a large fiber neuropathy, obviously length dependent loss of reflexes. In ganglionopathy, there's a diffuse loss of reflexes because it's like the whole DRG is affected. Posterior column reflexes are plus minus depending upon how much is the nerve is involved. And also coexistent nervous system is involved. Graded sensory loss is there symmetric in large fiber neuropathy. Ganglionopathy is always patchy sensory loss, asymmetric sensory loss. Sometimes you get the facial sensory loss, truncal sensory loss, patchy sensory loss is there. Posterior column, you get a vertebral level for the vibration. Motor weakness is there in large fiber neuropathy. There's no motor weakness in a ganglionopathy. You should get truncal sensory loss and trigeminal sensory loss. In posterior column, you'll get a girdle sensation and a Lermit sign. Suddenly flexing the neck, you get a Lermit sign of shock-like sensation along the spine. That is usually seen at the posterior column involvement. Sensory attacks in rhombic sign is in all three, but the severest sensory attacks is what you see in a ganglionopathy. Now, and some of the clinical pointers of neuropathy, sensory deficit in leprosy, the coolest area of the body, such as the nose, ear, helices, and the distal extremities. Tangiers disease can present with a bifacial weakness and proximal sensory loss, so including a syringomyelia-like pattern. Porphyric neuropathy is known to manifest as early and severe proximal weakness with a proximal pattern of sensory loss or a biting trunk appearance. Syringomyelia-like appearance can occur in a Forceman syndrome, that facial onset sensory and motor neuronopathy can also occur in that. Now coming to the reflexes, angle hyporeflexia and reflexia are commonly seen in large fiber neuropathy. Angle reflexes are typically preserved in small fiber neuropathy. Small fiber neuropathy, you get your typical nerve conduction also normal, your reflexes will be normal. Reflexes may be preserved in mild to moderate large fiber neuropathy. Reflexes diminished or absent angle jerk at age 80, sometimes people consider as normal, but it's really controversial. Whether it is any reflex abnormal absent is an abnormal reflex. Now, preserved angle reflex in leprosy, hyperreflexia can be seen in some amount of GPS, loss of reflexes in length-dependent neuropathy, and generalized reflexia may be seen in more like sensory ganglionopathy. Like this condition, all are important clinical pointers. Now, always look for any coexistent upper motor neuron involvement. If you pure motor is to, you can always think of a angiohundsland motor neuron disease as a differential. If there is a sensory with a coexistent upper motor neuron involvement, usually the B12 deficiency, copper deficiency, myeloneuropathy, vitamin D deficiency, HIV, Fetrix, adrenomyeloneuropathy, all these things should be considered. Unrelated to human, maybe an old stroke or a cervical compression, which unrelated to the disease, maybe coexisting, maybe the one which is maybe contributing to the coexisting human involvement. So some clinical pointers, if you have, for example, bilateral carpal tunnel syndrome and an autonomic dysfunction, you think of an amyloidosis. Dysautonomy and a proximal weakness, you think of Lambert-Eaton. All the patients with pure sensory neuropathy will have normal motor conduction. The loss of sensory feedback often can lead to some amount of some sense of weakness or abnormal motor function. They may not look completely normal motor-wise. Patients with poor motor neuropathies also, on the other hand, like multifocal motor neuropathy, may have some sensory symptoms with it, even though they don't have any objective sensory loss. So the range of motion of the shoulder and the presence or absence of scapular winging should be documented in any patient with shoulder pain. So, for example, a lot of patients with scapular winging and proximal weakness can may just present like shoulder pain, just like Parkinson's may have some amount of shoulder pain. So they should be examined. In critical illness setting, in development of weakness over days is most likely related to a critical illness myopathy, like thin filament myosin loss, but may be caused by critical illness neuropathy. And then symmetrical lower limb element distal weakness in lower limb more than upper limb. So it's some of the question of chronic neuropathy versus distal myopathy. Sometimes it's difficult to differentiate. Once the reflexes are present, it's more likely to be distal myopathy. Sometimes long-standing process reflexes may be absent. So sometimes difficult to differentiate. Early involvement of the intrinsic hand muscles are more commonly in distal hereditary motor neuropathy, as opposed to forearm flexors, which are involved more commonly in distal myopathy. Now coming to axonopathy versus demyelinating, features suggestive and demyelinating neuropathy, weakness without atrophy. So lung-dependent independent distribution. In demyelination, both proximal and distal are involved together. Early involvement of proximal reflexes or generalized loss of reflexes are more common in demyelination. Myokemia, palpably enlarged nerves, neuropathic tremor, all common in demyelinating disorders. Axonopathy is usually a distal predominant distal reflex, like angle jerk with preserved proximal reflexes. Then obviously when the disease progresses, they may involve proximal also. So you need to know whether that is in neuropathy is symmetric. Then you look at whether it is length dependent. Then sensory, if it is length dependent, or the motor, how they are involved in needs to be seen. We skip some of these because lack of time. Okay, neuropathy can present with significant early proximal raise the possibility of a demyelinating neuropathy. So when you have an initial significant proximal involvement, also think of a demyelinating neuropathy. So for example, CIDP is a hallmark of both proximal and CIDP, and the hip, especially a hip flexor weakness, is suggestive of a CIDP if you have proximal and distal weakness. And sometimes demyelinating neuropathy can mimic a length-dependent neuropathy, as in the early stages, like long fibers have the high probability of being affected. Sensory involvement of lips and mouth, and usually a long length independent process, probably a ganglionopathy also may be involved. So celiac neuropathy can have some amount of sensory involvement. So some clinical pointers towards. So finally, where do we localize? History and examination, you look at the functional neuroanatomy, look at CNS or a PNS involvement, look at the pattern recognition, which PNS structures involved, look at both multifocal or generalized. Is it sensory loss or weakness or both? Is it primarily proximal or distal or both? Is it symmetric or asymmetric? Is it acute or subacute in onset? So in nutshell, this table can, most of the things are covered in this box where you get a, that's the thing taken from the continuum. So you can have a proximal and sensory and motor involvement. If it's symmetric, it would have diabetic lumbosacral. If it's a asymmetric involvement, is mostly involved diabetic lumbosacral adiculopathy. If it's a pure proximal motor symmetric, it could be a, most of the myopathies are the one which present with the proximal motor and symmetric. If there is a proximal and distal, the symmetric is CIDP. CIDP, if it is asymmetric, you get a mononeuritis multiplex, MATSM, or in the hereditary part, if HMPP. Proximal and distal, if it is symmetric, a lot of condition can present with SMA, from SMA to proximal muscular atrophy, the MND. A lot of condition can be proximal and distal involvement with the symmetrical involvement. If it is asymmetric ALS, the monoplegic variants, the multifocal motor neuropathies, IBM, all this can present with asymmetric. So this table summarizes most of the things. So I will skip some of these and I will go to focal symptoms. So we know because I've tried to explain most of this in that one table itself. But when you look at each of the table in individually, for example, if you can localize it to a single name structure, it could be radiculopathy, plexopathy, or mononeuropathy. So you need to know the neuroanatomy for each nerve root, what muscles are affected, what is sensory distribution, what is the reflex level. So to localize it to each of the radical or plexus involved. So plexopathy is usually in the pain, weakness, atrophy, sensory loss, asymmetric, multiple contiguous nerves will be affected. Trauma is the most common, followed by the inflammation or infiltration or a post-radiotherapy involvement. Plexopathy also again same thing. The common is a trauma. It's same picture. Sometimes HNPP, the hereditary neuropathy with pressure palsy can also present with recurrent plexopathies. Lumbar plexopathy also the same depending upon the nerves involved, the roots involved can present with that. Mononeuropathy is mostly entrapment is the most common, where the carpal tunnel syndrome, or the ulnar nerve at the elbow, or the radial nerve at the spiral ring, the fibular nerve at the fibular head. There are other entrapment neuropathies are also there. They are the one which most commonly seen. Multifocal is proximal and asymmetric, so could usually a podial radiculopathy, polynuclear radiculopathy, radiculopexopathy, usually a carcinoma, lymphoma, sarcoid infections can also present with a polyradiculopathy in the proximal asymmetric involvement. That is upper limb proximal asymmetric involvement of radiculopexopathy involvement. Proximal and distal symmetric is usually AIDP and CIDP. Proximal and distal asymmetric is multiple nerve, like mononeurosis multiplex, usually vasculitis, leprosy, HIV, diabetes, lymphoma, MADSM, HNPP. All these things can involve in the involvement. So the mononeurosis multiplex is something which you see commonly, which you can see in exon, if it is vasculitis, diabetes, sarcoid, leprosy, HIV, hepatitis C. If you have a focal demyelination or conduction block is there, which presents like a multiple mononeuropathy, MADSM, or multiple motor neuropathy, or multiple compressive neuropathies, HNPP, can present with the focal demyelination also. Asymmetric polyneuropathies are usually entrapment neuropathies, radiculopathies, and plexopathies, vasculitis, sarcoid, CADP variants, MMN and MADSM, and other mimics like ALS or an FSSMD can mimic like an asymmetric polyneuropathies. So distal symmetric is the most common. Distal symmetric, the diabetic neuropathies that we usually commonly see in other drug toxic or paraproteinemias and all can present the distal symmetric sensory. Motor pronoun sensory is usually hereditary neuropathy. Some of the DATS variant of CADP can present motor sensory and tremor present. Pure motor, proximal distal symmetric. Usually it is you should think of a myopathy or neuromuscular junction involvement. SMA, CADP can present without sensory loss. PMA or muscle atrophy or Kennedy's disease, which can also have a sensory neuropathies. Multifocal or generalized pattern, pure motor, proximal and distal asymmetric, neurogenic, except for example IBM or FSHD, ALS variants or its variants can present infections, CADP variants can present in similar format. Distal symmetric and pure motor can be hereditary neuropathies or axonal CMTs or ALS and HSP variants. Sometimes distal, we discussed previously, distal myopathies versus distal neuropathies. And the EDB involvement may be help. Some EDB had the extensor digital and brevis muscle hypertrophy is more coming with a myopathic than and wasted in a neuropathic process. Distal and asymmetric ALS versus MMN, multiple nerve pattern versus myotome pattern. You need to know the identification of the each nerve and the nerve distribution of the muscles and the nerve distribution. MMN in a multifocal motor neuropathy is a weakness is out of proportion to atrophy, hyporeflexia, nereflexia. Hirayama and flail limb variant sometimes can present with the monomelic atrophy. One limb involvement can present the distal asymmetric format. Pure sensory are usually involved in sensory cord, sensory tract, dorsal root ganglia, sensory nerves, small adminate fibers. Most clinically will cause static loss in a fixed distribution. So episodic migrating paresthesia are all very rare, which usually we don't see commonly. So pure sensory depends upon the column involvement, which we discussed about the dorsal column versus ganglionopathy, large fiber neuropathy, how they are differentiated. We discussed just now. And if it's a pure sensory distal symmetric, that is classically is a diabetes sensory polyneuropathies. So in the pattern recognition in neuropathy, in summary, we'll try to identify which system is involved, motor, sensory, autonomic. What is the distribution of weakness, like distal versus proximal and distal focal, asymmetrical versus symmetrical? What is the nature of sensory involvement of burning sensation or proprioceptive loss, small fiber or large fiber? Is there any upper human involvement? What is the temporal evolution, acute, subacute, chronic? Is there any evidence of hereditary neuropathy? That's all we like to know. Like the key questions that we are trying to answer the questions. So this inherited and acquired, we have discussed it multiple times during our talk. Now, just a summary of how you recognize the muscle disorders. Muscle disorders are probably more easier because the most common pattern is the proximal weakness, proximal lower limb followed by proximal, there's a limb girdle weakness, but it is the least specific also. Most of the acquired and hereditary myopathies will have that pattern. If we have a distal weakness, usually seen in neuropathy, what are the muscle disorders which can present with distal weakness like FSHD, more myotonic dystrophy, IBM, inclusion body myositis, and distal myopathies, distal myopathies also can have a distal weakness. Proximal arm and distal leg, this classical presentation is in an FSHD. You can have proximal arm weakness, scapular winging, and a foot drop that you can see in a FSHD. Distal arm and proximal leg weakness that you see in IBM and also in myotonic dystrophy. Some doses without ophthalmoplegia, muscle disorders, that's very without ophthalmoplegia, you can see in congenital myopathies, myotonic dystrophies. With ophthalmoplegia, seen mitochondrial myopathies like CPE or chronic progressive external ophthalmoplegia, oculophageal muscular dystrophies, and sometimes neuromuscular junction myasthenia and Lambert-Eaton, rarely, but myasthenia more can be classically seen with ophthalmoplegia. Prominent neck extensor weakness, classically you've seen in ALS, myasthenia, AIDP, CADP, or in an inflammatory myopathies, you can see a neck weakness, but there are a lot of other conditions which can cause a prominent neck extensor weakness. Now coming to finally to summarize some of the basic investigations that you do in neuropathy. You do a routine blood test, you find out any systemic disorder is there in this patient. For example, in diabetic patient, you need not the HbA1c, fasting sugar, lipid profile, or any other. If you want to rule out other neuropathy, paraproteinemias, you will have perforce immunofixation, B12, MMA to rule out the B2 deficiency. Then if it is a mononeuritis multiplex, you look at the blood count, so the metabolic panel, HbA1c, HIV, hepatitis panel, inflammatory markers like ESR, CRP, the ANA and carbohydrate factor, complement levels, diabetes. This mainly you look at the vasculitis profile. This, if you're thinking of a multifocal motor neuropathy, you look at the GM and antibodies, CIDP or DATS variant, you look at the protein electrophoresis, the IgM paraproteinemias, you look for the MAG antibodies, or if you're suspecting POEMs, you can look at the VEGF, which vascular methyl growth factor, also which is highly elevated in POEM syndrome. If it is a ganglionopathy, you look at if you look at suspecting paraneoplastic, you look at the anti-WHO antibody, anti-Sjogren's, HIV, and rhodopsin levels are also being tested. In CSF, in a neuropathy, you look at the AIDP, you get the CSF albumin-cytological dissociation. If there is more cells, then you look at this HIV and CMV. In CIDP, protein elevated. But one important thing to know that in the absence of both clinical and diagnostic criteria that supports CIDP, just because CSF protein elevated just should not be justified to give any immunomodulator therapy. That usually happens when you have diabetes and whether this patient has CIDP or not. You do a CSF and find some protein elevation, you should not label every diabetic neuropathy as a CIDP. and like ENCS and EMG is part of the both nerve and muscle disorders. So you want to nerve conduction study to present the absence of the large fiber neuropathy, which is a predominant nerve involvement. There is a coexistent other compression or radiculopathies, the distribution of the nerve involvement, the underlying pathophysiology, the axonal or demyelinating, there's a symmetry or asymmetry, determine the severity of the polyneuropathies. It is an acquired or hereditary, or to repeat it during the evolution or the improvement, to monitor the therapeutic effects on the intervention. All these things have involvement of NCS, both NCS and EMG. Our MRI has been off late. It's been pretty significantly used. For example, if you get a hypertrophic enhancing roots can be seen in AIDP, CIDP, and CASP. Dynamic MRI of the spine, like flexion extension of the spine, can be seen in Hirae vertices to look for the dynamic compression. Focused MRI of the brachial and lumbosacral plexus can reveal different etiologies. Nerve biopsy has been coming. I mean, if it's been inheriting neuropathies come very low. We rarely do nerve biopsies now because we directly go for the genetic testing. Otherwise, the few conditions where we do nerve biopsies, the vasculitis and neurolymphomatosis, leprosy, or sarcoidosis. Skin biopsies, something which can help in identifying small fiber neuropathies. Genetics, gene panel, exome sequencing, and genome sequencing are increasingly being used for the hereditary neuropathies. In myopathy, the most common investigation that you do is creatine kinase, which is elevated in most of the patients of muscle disease, maybe normal in some slowly progressive myopathies, but degree of elevation also gives some diagnostic clue. So for example, very high elevated, it could be dystrophinopathies, dysphorinopathies, scalpinopathies, and some amount of drugs can also cause elevation in CK, which is given in the list below. These are conditions where myopathy, not only myopathy, MNDs, neuropathies, and non-neuromuscular condition also can cause mild elevation in CK. But when you have very high CK, for example, LGMD, you can always say that if you have a limb girdle muscular dystrophy with a calf atrophy and a plantar flexion weakness and a high CK around 10,000 CK, you can easily say it is a dysrhodinopathy. So that kind of clarity is usually seen in CK, high elevation of CK. For example, a 10-year-old child with a calf hypertrophy and a high CK, you can see if it's a Becker. Still, there's not much neck weakness. You can say it's a Becker or a sarcophagonopathy. So these are, it will help you in narrowing down your differentials and it will give initial diagnostic clue. Other conditions that we use, other investigation serums, CSF, lactate, autoantibodies for all anti-myositis antibodies that we see in all the inflammatory myopathies. EMG is mostly done for if you want to think about a neurogenic or myopathic process, sometimes some cases can get tricky. Muscle MRI and neuromuscular ultrasound has become more and more useful in identifying characterizing the muscle involvement. Now, single gene test, genetic testings are involved, whole exome, whole genome sequencing, and muscle biopsy. Muscle biopsy are also coming more muscle biopsy done for mostly for an acquired condition like inflammatory myopathies. And you're doing muscle biopsy now only after genetic testing becoming negative or any variant of unknown significant coming. We not to look at those factors to confirm you do a muscle biopsy nowadays for hereditary disorders. So in conclusion, I think I have 2 minutes left. So history and examination, general physical examination can give key clues towards etiology. Localization is very important, and pattern recognition, whether it is a neuropathy or a muscle disease or a neuromuscular junction, the pattern recognition is what narrows down the differentials in the neuromuscular disorders, and use investigations judicially and don't go for a fishing expedition. So if you have narrowed down your differentials, you can localize and investigate in that area to find out the cause. I think I'll thank you for the opportunity. Thank you.
Yeah, thank you very much, sir.
Yeah, 1 minute left.
Yeah, yeah, thank you very much, sir, for such a detailed presentation. And I would say that you concluded that presentation on time. I would say that before time. So
Yeah.
thank you very much, sir.
Thank you.
So as of now, like I could see one question, sir, on YouTube channel, that one of the user they asked. I think Padma ma'am joined during your presentation. So, ma'am, are you there?
Yeah, madam is there. I can see her name.
Yes, sir. Um, okay, sir. This is the one question that was asked by one user. Thank you, sir, for covering this important topic. As lot of patients present with significant disabilities since the introduction of UDID portal. What are the current practices at AIMS New Delhi? A person taking treatment from AIMS Delhi but belonging to Telangana can be issued the disability certificate, or she need to apply at their local government health facility. That's the question much.
Yeah, I mean, it's nothing related to to this topic, but disability. I'm not in the disability board anymore, but as far as I know, any patient who comes to AIMS and we treat it, we usually give it. If they ask for a disability, we can give a disability, irrespective of which part of the country you come from. So if we are treating it, we are likely to give a disability certificate.
I have asked the participants to write their questions. If there are any questions, you can type please in the chat box, or if you want to ask it, you can unmute. So,
I think there are no more questions. Everybody
Yes,
understood.
sir. Yeah, the same thing I was about to say, sir. Yeah. So,
I don't have no, I'm usually a fast speaker, so I speak very fast. So I try to slow down my speech, but after 15 minutes I lose control and again picks up the speed. So it's little difficult. But it was a vast topic also to cover both
yeah,
nerve and muscle together in one topic. It's little difficult. We usually to split it up in two and two. But still, I think most of the things which have covered, at least you have a recording, at least you have most of the slides, most of the things are self-explanatory. So they may be able to, if you go back
right,
and if somebody wants to go back and revise, they should be able to. So most of the things are summarized in the slides.
right, sir. Right. So I
Thank
think
you.
with this, I would like to invite Professor A.K. Sood, sir. He is Deputy Secretary, National Academy of Medical Sciences. I would like to invite sir for the vote of thanks. Sood, sir, please. Sir, you are muted, sir. Please unmute yourself.
Thank you so much. On behalf of the National Academy of Medical Sciences, we are grateful to the distinguished speaker for this evening, Dr. Vishnu, for being with us and covering this complex topic of nerve muscle disorder in a very simple way. I am sure that the practical tips which you have given will be useful for our participants, especially to the students. So thank you, sir, and we look forward for your support to the Academy in future also.
Thank you.
I will also like to place on record the support which we have been getting from the chief coordinator for this series, Professor Padma Srivastava. She is head of Department of Neurology, All India Institute of Medical Sciences. She has been the key person for this series on neurology. She has identified the topic as well as the best speaker. So we'd like to thank Madam also for making all the arrangement for this series. Thank you so much. I will also like to thank the participants who have been with us this evening. And just for the information of the participant that the last session of this series is on 10th of August, and the topic is approach to a patient with headache. So in case you have any question and queries, so please email to us. We'll try to put it to the speaker so that these can be taken care of in the next presentation. I will also like to thank the moderator for this evening, Dr. Jaswant, who has been helping us from the very beginning for moderating the session so well. Thank you so much, Dr. Jaswant. In the end, I would like to place on record the support which we have been getting from our IT team, Mr. Ravi and Mr. Anil, who have been helpful in the background for arranging the transmission of this session on YouTube as well as on the Zoom. So once again, I will like to thank all of you who have joined us this evening, and thank you once again. Over to you, Dr. Jaswant.
Yeah, thank you, sir. Thank you very much, and again, thank you, Vishnu sir, for the wonderful presentation. So I think with this we can conclude this session, today's session. Thank you, sir.
Thank you very much.